is the interim Chief Executive Officer of University Hospital Sussex NHS Foundation Trust and is a consultant obstetrician and gynecologist by background, having worked across London and South East in both clinical and executive leadership roles. Andy will be talking about what's happening on the ground and how they are improving care. Over to you, Andy.
Thank you very much, Naeem, and thank you, everyone. As known as I'm Andy Heaps, I'm the Interim Chief Executive at University Hospital Sussex, trust I joined in 2021, and prior to that have been a Chief Operating Officer and then a Consultant Obstetrician and Gynaecologist. And my special interest as a Consultant Obstetrician and Gynaecologist was maternity safety, and I was a labour ward lead for one of the largest single-site labour wards in the country at Barking, Havering and Redbridge University Hospitals NHS Trust. I want to talk today about what's been happening at University Hospital Sussex and how we're improving care. But I want to start by being direct about something important. So as Kate has described with Cornwall, over recent years, our maternity services have not always delivered the standard of care that women, babies and families should rightly expect. Some families were let down. And we're also one of the 12 trusts included in the National AMOS review. And I'm not going to shy away today from being part of that review and working with them so that we can share our learning and learn from other organisations as well. So my responsibility as Chief Exec, I think, is not much different to my responsibility as a labour ward lead. It's to ensure we learn from these experiences, act on what they show us, and build a service that's reliably safe, compassionate and centred on women, families and babies. There are a lot of slides here, which I'm not going to dwell on for too long, but I want to make sure they're in a pack that comes around so that people can see the whole journey that the Trust has been on. So if we go forward a couple of slides, please, Carl. Quite similar to Kate's story, actually. So we're one of the largest trusts in England. We serve women and people across a large, diverse geographical area. Got 4 acute hospitals, and each of those has a labour ward as well as a home birth service. And we deliver about 9,000 babies every year. So that's in the order of 2,000 to 2,500 deliveries on each of our sites. In September 21, the maternity services were inspected by the CQC. 3 of our sites rated as requires improvement, and then the Royal Sussex County as inadequate. And again, similar to the story that Kate told, the warning notice was served with immediate requirements for improvement. We joined the National Maternity Safety Support Programme in February 22, and then the CQC came back for an informal visit in April 22 and showed recognised the improvements that were being made, and the warning notice must do and should do actions have all now been completed. And we've just finished a round of all 4 sites being re-inspected. We're waiting for those reports to be published, but no immediate actions were required for any of the sites. So we have an improving story to tell. I want to touch on the MSSP on the next slide, please, Carl. So we entered that in February 2022. Together with that national programme, we developed a maternity and neonatal improvement plan, which was monitored under a bi-monthly chief nurse-led maternity and neonatal improvement group. That wasn't just a trust programme, but external stakeholders, including the CQC, our local maternity and neonatal voices partnership, and the regional chief midwife. We've put about £1.5 million into leadership, specialist roles, and clinical and governance roles. A review and reset by the MSSP and regional and national stakeholders were held in May and November 2024, which found demonstrable improvements from ward to board, which I'll talk about shortly. And then 4 review actions came together in July this year, which let us plan for an exit meeting on the 5th of August, which has been paused pending the AMOS review. And then on the next slide, we've really tried to do this with our staff. So we co-produced a vision. So we did a huge sort of big conversation listening event and took all of those words and put them through some AI to find out what our staff wanted our services to look like. And their vision is to be a leading provider of maternity care where supportive, compassionate care, kind communication create a safe empowering and personalised experience for all families. And that was really important for me because that was the vision that our services had created. It wasn't about me going in saying, this is what you have to do. My job then became about how do I enable this team to deliver that vision. So if I touch on some of our outcomes over the last few years, because I am a big believer that data should drive all of the improvement work we do. So if you go to the next slide, please, Carl. So this is Embrace data, so it only goes up to 2023. But you can see that against our peer group, our mortality rates by year, both stillbirth, neonatal mortality and extended perinatal mortality, since 2020 has been lower than our peer group. But we've not really found that this data has been tangible enough for us to understand how the changes we're making in real time are having an impact on services. And again, on the next slide, again, it's 2023 data, but you can see the darker circles here are University Hospital Sussex, and you can see that our in terms of our stabilised and adjusted data, as well as the accrued data, we perform better than peers. More helpfully, I think, and the data we share with our trust board is a little more detailed. So on to the next slide, please, Carl. This is our current outcome data all the way up to September this year. So you can see our stillbirth rolling rate, and the dotted red line is where the trigger point for concern comes. And you can see that since April 23, we have significantly reduced the stillbirth rate and the perinatal mortality rate at University Hospital Sussex. We saw an increase in neonatal deaths across 2024, which triggered an investigation, and the outputs of that, again, only coming up to the threshold level, and then again improving numbers since May 25. So we are really trying to use up-to-date live data and using SPC charts to understand where variation, if it's special cause, and then trying to understand the drivers behind it. If you go forward on a couple of slides, please, Carl, and the next one. Colleagues will be aware of the CNST, the NHS Resolution Maternity Incentive Scheme. We had struggled to fully complete that across years 1 to 4. Year 5 was the first year we had full compliance in April 2024, and then in year 6 we've confirmed full compliance in April 25, and we're on track for year 7. That obviously brings back a rebate from NHS Resolution, which we've been able to use to pump prime some of the improvements we've been trying to make. But engagement with that programme is incredibly important to show that we're doing everything that's expected of us in order to drive improvement. Another important piece of the jigsaw for me is service user data. And so if you go on to the next slide, the CQC maternity survey in 2024, we were ranked 18th from 22nd in 2023. The 25 results are embargoed, but I have been able to share with the service that there's been a further improvement in their ranking. So people are telling the CQC that they're getting good care. The big key plank to improvement for me is looking for the biggest driver of concern and then working it down until it's resolved. And if we go to the next slide, from January 2020, so from before I joined the trust through to November 23, we had 13 HSIB cases involving cases of telephone triage advice. So either advice that was reported as being wrong or the phone wasn't being answered. So in March 2024, we launched a central service for all 4 of our maternity units. So there's one single triage service that acts as a hub. And since that's been in place, we have had no incidents HSIB reportable involving telephone triage advice and advice to women people to come in. We get around 3,000 calls per month to that, and all of those are recorded, which means that we can quality assure them. We've also seen a 40% reduction in women who give birth before arrival, which is I think a really useful metric for our women people being given the right advice about when to come in or not. It's also really important for me that we look at our data through a lens of inequalities. So on the next slide, One of the bigger populations of health inequality that we serve are asylum seeker and refugees. So we've established an asylum seeker and refugee pathway. So some of the work we saw in our data, it was this community that were experiencing poor outcomes. We now have bespoke antenatal clinics, antenatal classes provided in 9 different languages, and they're signposted to the local maternity neonatal service website, which is completely translatable so that families have access to data in their mother tongue, which I think is also incredibly important. We've also worked with families, so our Maternity Neonatal Voices partnership is a really important group, and they have co-designed our improvements with me, and I meet with our MMVP because they give me a sense of what's going on in the service out with my own sort of triangulation. They've supported us to introduce birth supporters staying overnight. We've improved our bereavement services. Our discharge processes have improved. It's supported improvements in our home birth service, and they do visits with us to support environmental improvements. We had a service user summit in March this year, again to drive sort of learning in our 4 units. I think to the point that Kate made earlier as well, one of the big important pieces of work we've done is launching a restorative culture programme. So this is led by expert facilitators who have lived experience of baby loss, and they've co-designed a programme alongside us that can be offered to families and staff, which offer support and restoration to the families who called for us to be included in the AMOS review. That's currently paused due to the Secretary of State's announcement. But it's an offer of support and restoration to staff who've been involved in difficult incidents or investigations, community outreach, and then we've just started a restorative culture education programme so that all of our staff, medical, midwifery and admin, get trained in that. Then just want to touch on some of the workforce improvements. So if onto the next slide, we're really proud of this, but our core midwifery vacancy rate, which was around 20% in July 2024, we are now over-established, which I think is great because it just gives us flexibility. We're able to maintain one-to-one care in labour. We have an incredibly low midwifery support worker rate, and our neonatal nursing vacancy is reduced to 13% in September. We have further to go. We've also now got bespoke clinical leadership on each site, together with trust-wide clinical leadership for obstetric and neonatal services, which lets us start to drive some of the unwarranted variation out of the services that we have. By supporting our teams, and again, Kate and I hadn't rehearsed this together up front, but we have used the Improve Well app to help staff share their ideas and share where they can make improvements. We're a big trust. The geography we cover is 40 miles by 30 miles for our 4 units. It's important that we're able to talk to everyone. Microsoft Teams helps with that. We have listening events where our board champions meet with any member of staff from the maternity services who wants to come along. We also have a communications team dedicated to our maternity services who provide a huge amount of material trying to keep people in touch with what we're doing. Work still to complete. Staff survey was there, but you can see that that's improving. But in terms of work we've still got to complete and challenges we've got, so transitional care provision impacting on postnatal capacity. So we need better transitional care services so that we can clear our neonatal units for those babies that really need it. We have quite old labour wards and the capital to refurbish them so that we have separate theatres for planned caesareans is a challenge we're working through at the moment, whilst balancing against our elective and cancer surgery challenges. There are still pockets of low morale and staffing issues that we're working through. We have too much variation in our clinical guidelines. I've talked about our estate issues as above, and some of the changes to ICBs coming. So the LMNS, the local maternity neonatal system meeting has been really helpful. That will be going as part of the ICB changes. So working with system partners to ensure that that voice remains in the future is a key ambition. So I'll wrap up there, Naeem. That's just a whistle stop of the work we've been doing over the last 4 years.